folks will trickle in. Thank you guys for joining in person, those of you who are here, and thank you to those of you who are online for joining online. It's really a pleasure to finally have Bruno here. I mean, he's been in Baltimore now for a couple months, but to finally have him come and talk to our department. And I'll tell you a little bit about his background. If I were to tell you everything about his background, we would be done with the talk before he got to talk. So I'll try to be short and brief. But starting in October, Bruno Andrade joined our department. He joined the Division of Infectious Diseases as his sort of primary home in the School of Medicine, but with a joint appointment in our Department of International Health here. He's a physician scientist. He's internationally recognized for contributions in immunology, infectious disease, translational research, and global health. And he was, before coming here, he was the chief of the Laboratory of Clinical and Translational Research at the Oswaldo Cruz Foundation in Brazil, one of the world's leading biomedical research institutions. And then he served, and also as scientific director of Monster Research Institute, which is dedicated to nurturing young scientists from low and middle income countries and improving health among vulnerable populations, including indigenous, homeless, and incarcerated peoples. Bruno brings extensive experience in global health to our community across many different domains, including data science and artificial intelligence, precision medicine. But I think what you'll hear about, which is really quite striking in my mind about Bruno and what he's been able to do, are two really fundamental things, which bridge across many different content areas. One is really the ability to have the vision and strategy to bring together enormous networks of people to accomplish very big things, which he will talk a little bit about. And the other is just the passion and dedication to capacity building and training and ensuring that you're building a foundation for the future. And you're going to hear a little bit about some of that. He's worked across a lot of different data science, AI applications in medicine. And I think a lot of the effort from the medicine side to bring him here was really around that data science piece, but has also worked in the sort of climate and health and worked extensively with indigenous populations in the Amazon, which I think fit very nicely within some of the work and the strategy of our department. So again, I'm not going to go on and on about all of his amazing accomplishments. He's worked in many, many parts of the world, including South Africa, India, obviously Brazil, and trained here in the United States. And you're going to hear a bit more, and I'm going to get out of the way. And thank you so much for joining us, Bruno. Thank you.
Thank you so much, Judd. I'm actually very happy to be here finally and have the chance to talk. And what I decided to do today when Judd invited me to give this talk was to really compile a bunch of things that we've been doing for the last 10 years and show with the idea that we can maybe find collaborators or connecting with whatever you guys are cooking. And I tried to study the school and the department before building slides. But before we go into the TB studies, I really wanted to show what we try to do. So I was trained in Brazil in medicine, and then I moved to US to finish my training at the NIH. And then I moved back to Brazil because of Zika. I was fascinated by Zika. NIH needed help there. And my job was to build a network, to build this, what they call the ZIP study, to understand what was going on there. And we study a lot of different diseases, as you can see there. So, but the main point, let's see if I can see, what I was trying to do, can you see? Yeah. Was to understand disease outcomes upon exposure. And if you look, the production of the team, it spans from leishmaniasis to dengue, Zika, and TB and HIV. Most recently, the lab is more focused on TB and HIV. And it's really trying to understand upon exposure or infection, a host can develop a variety of outcomes from complete resistance to infection to resistance to disease or disease tolerance or mild or severe diseases. And we've done this in several countries. I had the chance to work in 17 countries and mostly sub-Saharan Africa and Southern Asia. And doing this work that has been now done for like 15 years, the idea was to build research capacity and allow the local communities and empower them to run the studies. When we moved back to Brazil, Brazil was facing a huge economic crisis in 2014, between 14 and 15. And to do what I was trying to do, it was not feasible because there was no money for research. It was absolutely nothing. So we had to build from scratch, and we decided to do a risky thing. So we built groups, and we transformed these groups into NGOs or institutions to try to get grants or fundings from different sources and to increase the likelihood of getting support. So that resulted in several groups. Two of those will be discussed today here. And then a telemedicine company, a medical education AI-based company, and a precision surgery training system that records residents operating and then ranks them, and it teaches them in real time how to do things. So the idea was to use heavy technology with the field studies to boost the capacity to promote research capacity building, and a lot of young investigators from countries like Mali, South Africa, Uganda, the Philippines, and so on. So to build the field studies, we use a lot of portable technologies, from retina screening to digital X-rays enabled with AI, ultrasound point of care ultrasounds, and body composition estimations. And we built mobile facilities that will go from and river-based facilities, river boats that will go to the Amazon. I will show you some studies, but also several prisoner units providing care, and also for like homeless people deprived of liberty. So we wanted to study hard to reach populations in hard to work conditions to make this happen. And we were quite successful in obtaining grants to do that. One of the top priorities was to invest in humanitarian health and indigenous health. Just as a side note, this is very distant from my early career stage when I was studying cytokines and immune reconstitution syndrome. So everything has changed. So we built this health center in Parque das Tribos, which is the largest urban indigenous communities in the world, in the periphery of Manaus in the Amazon. And we have there 39 different ethnicities living together as a big neighborhood with characteristics that can go from slum-like settings to complete urban settings. This population is invisible to the health system because they are considered indigenous populations. So if they look for a primary care center in the city, they will tell them to actually seek for care at the indigenous health unit. And if they go to indigenous health unit, then they say, well, look, you live at the city. So they're in this gray area, and the authorities had no idea about the burden of several diseases that we decided to study. But in order to be accepted by the community, we needed to live there and to show that we were working together. We just did not want to use their data and to get their specimens. So we built several things, including primary healthcare centers. We created the first indigenous health residence in the country that was attached to this program. And it's just to show what we've been cooking, and maybe if you guys have ideas of how to interact, we are here to collaborate. We built with several medical schools in the country an exchange program that students and faculty can go and participate in the surveillance studies that we have in different parts of the Amazon, and also with incarcerated populations. And that's pretty much what I wanted to show. Look, we've built all of this, and with the move to Hopkins, the idea is to keep that infrastructure and involve more of the Hopkins faculty with initiatives. So we are discussing with the Center for Global Health to try to design an exchange program for like students and faculty to go there and spend time with us at the river and in different settings as well. Things are progressing. So today, now the talk, the real talk is about 3 points that I wanted to make and that we've been trying to develop. And I think has a lot of communication, let's say this way, with the school and with the department. And it's to, this is very small. We will show to you how we decided to handle with the national data and to link that with the cohorts that we've been building, and how that could provide and inform policy. And then we overlay that with climate data, how we've been playing with that. And I thought that could be interesting topics to discuss with you. And why Brazil? Not only because of the beauty, this is Rio de Janeiro, but Brazil has a lot of interesting features when it comes to TB. Has a high burden, so 1/3 of the TB cases in the Americas is from Brazil. Then the same time that the burden is high, Brazil has a very interesting centralized care that spans all the way to primary care facilities, but with integrated data. So the entire country has disease notification systems, vaccination databases that, if allowed, we could, at that time we imagined that we could link all of those databases and link with the government incentive programs and all that. And we can really delineate the profile of people. So we've done this to 100 million Brazilians, and that's called the 100 million cohort. That's a Fiocruz sponsored project together with several universities, including London School, that has done heavy lifting, creating these data centers to allow this linkage to occur. So then we have in almost 1/3 of the Brazilian population, all kinds of information regarding vaccination, laboratory exams in the public health system, and a bunch of other things for more than 24 years. So we are digesting that data and getting ready to explore it different ways. So then what we decided to do, okay, let's take our initiatives of building research infrastructure and recruiting participants in hard to reach settings, and then merge that with the national databases to try to infer different things, as I'm going to show in the next slide. And to convince the government to provide access to data, we had to build data centers with secure infrastructure, and everything was built from scratch. The other thing that we decided to do is every linkage and every new analysis that we do with the public data, we build dashboards to the government to inform policy. So they can model, they can model interventions and and do all kinds of things. But the beauty of this dashboard is this: it has a recursive system. So anytime that a new case shows up anywhere in the system, that's captured and then uploaded and updated. And so the health secretaries or the Ministry of Health can easily access and see real-time trends. This is particularly helpful to track epidemics, right? Especially dengue. And we have worked with several, when I say we, as Fiocruz has worked with several investigators, including here at Hopkins, to describe different aspects of the dengue epidemic. So the example that I'm about to show uses two systems, the national registries. And as I showed to you and I discussed previously, there are several types of databases, mortality, laboratory exams, diagnostics, and all kinds of things. And we integrate that in a data center and we cross that with our own cohort. So we have the largest TB cohort in the country. We published a couple of papers comparing this cohort to the national cohort of TB from this public databases. And we found very important similarities that allow us to use as a validation platform. So we have a deep dive into the biology of our participants from Report Brazil. Report Brazil is part of this, and it is an observational cohort of patients with pulmonary tuberculosis and their contacts. And we follow through the treatment and recording data and specimens for up to 2 years. In different parts of the country, we have 5 different sites across countries with harmonized protocols and repositories. And we used to answer a variety of questions, as I'm about to show. And then we decided to use the CNON and the publicly available databases to really help us model and inform policy using this double approach. So the framework that we plotted and we presented to the Ministry of Health to get access to data and make that all possible has 5 different components. Understanding transmission dynamics in TB in several different settings, and then understanding preventive therapy and disease therapy, and then early diagnosis, treatment, and how do I help design better systems. So the first thing we found when we were starting to explore were like very basic things: who transmit TB, who is transmitting, who is responsible for the disease transmission in our highly controlled cohort. And so we had index case and their contacts. We could track with very simple analysis, and we found a couple of things. And now all households are equally likely to transmit. So we found features that were associated with increased likelihood of transmission. That includes diabetes and other things you can see here, persistent cough, and other things. So we validated those results in a larger national database, providing evidence that there are specific features in the households that needs to take into account to guide policy instead of treating absolutely everybody, and that increases the cost. So the other thing that we explored was to understand the cascade of care. That was surprising for us in a controlled observational cohort study. That the majority of the household contacts, they actually are not investigated. So we are losing a lot of participants right in the beginning of the cascade of care. So why, right? So we found a variety of reasons, but you can see here, we found that if you have HIV, you have there was a robust increased odds for missing the cascade of care at some point. Low education status, and at a lower magnitude, self-reported race was also associated with these unfavorable outcome, like loss to follow-up. And we are still digesting that at a national level to understand with the latent TB treatment databases to understand what exactly is going on there. We found interesting things that I'm not showing here due to time, but we found that indigenous populations are actually treated well. They actually tend to follow all the steps of the cascade of care, suggesting that once we diagnose them, they can actually go through the entire process. And maybe it's because of the indigenous care. Maybe it's because of the setting that the indigenous communities are located. We don't know, but we thought that was a very important data. So we leverage Report Brazil to actually understand better the associations, and because it's a controlled study. And then we use the national surveillance system to project and to model and inform policy. One example of the that we've been playing with the data from the public health system is the implementation of the short course therapy, the 3HP therapy. So it turns out that there was a highly successful approach in Brazil when you started treating people for a shorter time, and the uptake was gigantic. So we had an increase in almost 60% of the implementation of TPT. And if we did not have that, so we modeled that for the government. And now Brazil is implementing the ultra corridor, that is like 1 month treatment, and we are doing similar analysis to see the cost effectiveness of this and how reliable is the implementation, and the expansion of the TPT program. So it's not about just the uptake. We saw increased completion and value, and you're actually saving money implementing at the national level and promoting the TPT in the country, just with the logic that, well, if you wait for them to get sick, the treatment is more expensive. Some countries are going into a different direction, like India, and the idea is that to treat everybody, but I think we are missing a very refined cost-effective analysis to understand what to prioritize in this field. So the other modeling approach that we use was just to see by implementing expert as an example, we could increase not only the detection of new cases, but detection of resistance, and we could tell the government saying like, look, if you had implemented this, you could have saved a lot of money. And that's the kind of approach that we do. All of these papers were designed not to result in publications, but to inform policy. And the way that we found that we could convince the government to make changes is to actually publish the paper and then show them what that paper meant to them. So we advanced this in other ways, predicting outcomes. So we developed a prediction model for the report cohort for treatment outcomes, and we found a combination of markers, of biomarkers that could tell us with an accuracy of 77% who was going to fail treatment or recur or die or just die during the follow-up in a composite score system, because the sample size was small. Then when we look at the national level, we could develop a very interesting prediction to assess at baseline with very easy variables, easy to measure variables, the risk of follow-up, loss to follow-up. So if you know that someone is going to be lost to follow-up, then you can design a better way to keep, maybe with household visits or other approaches. This is particularly interesting. Was an MD student that came to me and said, like, why don't we tell the government that we are missing the battle, like we are losing this battle against TB, and we can quantify that, and we can actually tell the government what they should do to reduce this gap. We calculated the cost for TB case, and also the cost of TB care in the whole country, and then we divided pre-strata. I don't have time to show this paper here, but this paper is very interesting because we defined the NNT for the DOT, and we found that specific populations, there is this tremendous cost benefit of intervening just at that level. And we could start from that and have a huge impact of the national incidence of TB. So even with the combined strategies like increasing TPT, DOT, bigger focus on priority populations, we're still missing the relevant targets for the TB program. That was very interesting because we got the call from the Ministry of Health saying like, look, we have a problem. You're telling me that I'm failing. I invested billions of reais in this program. What are we doing wrong? And I was like, well, maybe we can co-create a new program. And that allows us to build the TB programs in the indigenous communities and the TB programs at the prison units. That's how we decided to do that without NIH grants, right? What the work so far has shown to us is, well, we need to find where the disease is and concentrates, and that's exactly what the group is trying to do, to define subgroups that are highly susceptible and how to intervene in a different way, in a kind of a precision public health measure, and inform the government with dashboards and modeling that are updated in real time and try to answer important questions, including cost of things. There is a paper that is being analyzed right now, reviewed right now, that we then test the approach of pooling sputum samples. So there is a debate about this, how many samples can be pooled, in which circumstances, which subpopulations should we do that? Is that efficient in a surveillance, active case detection approach or not? And we are addressing all of those things. We test these policies using these large databases at scale, and then building decision support for the government and the local communities as well. What is interesting about these things is every time we have this field work, and sometimes we spend like 2 months going to 15 different riverine communities, it's to actually talk to the communities because sometimes they do not have care, right? There is no physician there treating them. So how to approach the community in a way that they feel empowered to actually claim for what they need to and to fight for what they deserve. And that's been a life-changing experience just to be part of that. And they allow us to help them to improve their lives. So then I'm shifting gears just to show a little bit of climate. The climate, Brazil is a fantastic laboratory for climate research. And the reason is it's diverse. It has the Amazon in it, and it has the Pantanal, has the wildfires and all kinds of problems. Gigantic cities as well with pollution and all the problems that they come with that. And we're already suffering with the climate change problems. Last year, we had a tremendous fatality in the south of Brazil with rains. And then the same year, we had like a huge drought in the Amazon. We decided to just pick this problem of drought to show to you how crazy this is in Brazil. And to show you as a model, but I would love to touch base with experts in climate research because we built this repository and the data lake for climate data in Brazil, merging all kinds of things for the last 24 years. And we are ready to digest with help. And together with the, I showed you publicly available data for TB, but we have curated databases for dengue, for all kinds of diseases. And that's, I think it's just a rich environment that can be thoroughly tested with novel analytical approaches. This picture, by the way, just shows the devastating impact of drought. And that's in Manaus, the large city. But I will show you a satellite picture showing that how dramatic a drought is and why is that a climate dramatic problem in the Amazon. So the idea of building this data lake and investigating TB and other diseases, can we anticipate these interactions between climate change and events and right? So respiratory diseases for or harbor viruses and all. And can we effectively prepare to face those problems? And can we model that for the future? So we created this NGO, it's called FACE. And we have two large ongoing projects that are funded by Wellcome Trust and other international and also national funding agencies. We built this very large database, not only from Amazon, but the entire Brazil is already available. You can access here, and it contains data on wildfires, but air quality index, all kinds of weather projections from the national systems there. Just the Amazon has more climate laboratories than any other part in the world. So we leverage the data. And to be honest, it was really complicated to start this building that. People would come to us and say, like, why are you building this? You're not allowed, like it won't be possible to digest and analyze everything. It was like, I'm not doing this for me, right? It's just a way to provide a robust platform for the world and everybody that is interested in that. And you can just access, you don't need to pay anything or be part of anything. Just so you know, the Amazon is also problematic for TB, is the state that has the highest burden right now. There is this amazing thing about the state is 99% of the transportation is river-based, and it's highly susceptible or vulnerable to droughts. This is a picture of the largest river in the Amazon, and portions of that river completely dry. And so how you face transportation in something like that. That's a pre-drought picture and post-drought picture. And we hypothesized that we wanted to test the hypothesis that, well, what is the impact of these several droughts? And we studied the periods of the most severe droughts in the history of the Amazon. There were like 4 periods. And to test whether that would affect the cascade of care, how, and in follow which pattern. So this is just to show that the entire Amazon state is divided by like 9 zones. We study all of them. And this, the letter B here is showing just the population density. And it's not surprising, it's mostly concentrated in Manaus region. And this is very interesting. That shows the roads, and you can see that, well, almost no roads, almost no highways in the state, and everything is based on river. And then this is a concentration of healthcare facilities. You can see that the concentration is in Manaus. You have scattered dots across the state, and we wanted to investigate these regions and the main rivers. And we had to understand geography and river dynamics and all that in the cascade of care. This paper has been just accepted in Lancet Planetary Health. The most dramatic effects that we found was like in the 3rd graph and the 4th graph, just to use an example of the findings. And this is the incident rate ratios of the drought period compared to pre-drought period. And we see impact on consultations and other parameters here, including death. So during the 3rd drought, several rivers affected directly, right? Number of consultations and increased mortality in the Manaus area. Then after there was like a lessons learned attitude from the government, and they redesigned the healthcare system, and that is discussed in the papers. And what happened in the 4th period of drought is that the impact was mild and actually increased the consultation during that. And we can discuss in details after the talk, but we found in all of those periods dramatic differences in how the drought affected the services, both for TB and HIV as well. this is a real picture of a cacique, a leader of a community in one of the largest indigenous communities that we were studying close to Peru border. And you can just see that it's not possible to take medications or anything like that. Well, just to be like to bring this up is aside from the research that we've been doing and the a bigger issue that we want to solve is bringing knowledge and empowerment of these communities. So we decided to build together with partners a school program that we go into the schools in the indigenous communities, but also from families of incarcerated people, from homeless families and all that, to actually teach these kids how to read, how to interpret, how to do science, and how exciting science is. And we have a program that developed their careers. So we pay tuition fees, but we give computers. We teach them how to work on how to analyze data from their community to inform how they must change or how they can reassess something that is naturally impact. And that's the beauty, I think, from all of that. And many of the fellows that were nourished, that received this nourishment became scientists. One of them is Beatriz, that is joining as a faculty in July, I think. She represents people that we developed in these programs. So that required a lot of funding, and we were lucky because we found local entities, but also international entities that were aligned with our mission. And then we could, join efforts and propel these people everywhere in the world. This is the most recent meeting that we have in Bahia with the fellows that we developed in the last 10 years, just in Salvador, and we have several other cities. And that's the team from Report Brazil. And I'm here to take any questions and discuss ideas.
Excellent. I don't think you need me, but I'll stand up.
Just sort of people I'm laughing at.
So I mentioned before that I run the climate change sort of interest group, strategic planning group in the department. I'm actually an economist by training. My background's in development economics primarily. I'm particularly interested in infectious disease. We've done really similar work to your dashboard burden estimation with respect to Gavi countries and trying to estimate disease burden and predictions and economic impact to show how different vaccines and different burdens might shift over time and what the economic, implications of that are. So super interesting to see this in Brazil. The stuff that we did in Gavi countries was like super complicated because it's really hard to get the nuanced data for a lot of things. And we have this huge consortium of epidemiologists at a bunch of universities, like trying to pull data from the best places they can, but like there's not these sort of robust data sources. It seems like Brazil, and I've done some work in Ecuador, which had some similar, investments in setting up case surveillance and some stuff. And I've done some work in Brazil, but Brazil has phenomenal healthcare data that it's collecting. They clearly, at some point in Brazilian history for development, data was a real big priority. And so you're building on this infrastructure that's gigantic and that you can add other things to, but there's some like very fundamental, huge infrastructure. How replicable is that other places that you've worked? And like, have you used anything that you've done building upon that infrastructure to convince donors and convince investors that, hey, we couldn't have done any of this without this initial investment that happened a decade ago? How can we encourage that in other settings? Because we can really use that to improve a bunch of things. And I'm wondering if you have experience with that.
Thank you so much. This is a fantastic question. We couldn't, right? Unfortunately, we tried in Peru, we tried in India, we tried in Colombia, and in Africa, and we could never find something structured as the Brazilian data. So for economics, if you fill a form online requesting the cost of everything, and you have a nice justification, and if you were a scientist associated with the Brazilian institution, they will provide you data, right? So it's they de-identified and sent you the data. So what my group and other group did at Fiocruz was we just merged everything in a gigantic database. So you can go back and look at costs and for that particular participant that dropped out and was reinserted in the system as a second treatment. There is a paper showing the retreatment of tuberculosis. But we negotiated directly with governments from everywhere. And we could never find, even in Europe, it's hard to find systems that are designed that way. We've been, able to sensitize together with funders is initiatives, but they're very slow motion, let's say this, in South Africa, in India, in the Philippines, trying to integrate that. China has a robust system, but it's very different as well. It's hard to find the nuanced associations that you were referring to. So I maybe I failed. I don't know. We tried a lot just to see if we could reproduce some of the analysis elsewhere and validate analysis instead of results, and we couldn't find.
Have you done anything to quantify the return on investment or something like that of some of these evaluations to showcase like this is downstream value of investing in these data systems? I'm just trying to figure out ways to encourage investments from the global north to other places in the world for this type of infrastructure. And it's hard to justify from a lot of things, but this seems like an avenue to potentially justify this, like resulting in actionable, equitable
We
change.
would love to discuss it. Yeah. Love to. Well, even US, right? Yeah, I have friends who are working with clumsy data, but it's very different from this type of data, right? We are not talking about the people with health insurance. We're talking about potentially the third of the population that is the poorest, right? Because it's assisted by the public health system.
Hi, my name is Nia. I'm a PhD student in the GDEC program here in our department. I have a question about the climate shock data system. How was that built, aggregated, and how can that be applied in other contexts?
What do you mean by other contexts?
Or so the example here was in Brazil, and how can we use it in other countries that have similar?
Yeah, so it took us 3 years to come up with a digestible way. We even wrote an opinion piece about that. So everybody talks about climate, but everybody publishes about average temperature at the state level, or sometimes at the country level, right? What does it mean? So when you go deep into the granularity of the climate data, it becomes a huge problem because the databases don't talk to each other, right? Sometimes we have the metric that is measured daily. Sometimes it's 3 times a day. Sometimes it's once a month. And then a station breaks. So you lose that information. So we decided to have at the municipality level. So all the databases that we build is at the municipality level at a monthly base. So we have for the last 24 years, monthly based data from every municipality in Brazil on all those variables. I am about to see another, just like the health data. I know that the climate data is available, so you can just go to NASA and download the data. The problem becomes how to integrate that and curate those databases to be digestible. And I haven't really seen, but I'm not from this field. I'm just starting with that. But I'm more of a data field scientist. I haven't seen data like that, you know, that's why we wanted to make available online, right? Yeah, but I'm not sure about other groups that have built such databases that you can just pick and choose and play with the variables and because the database is built in a dashboard format, so you can actually visualize those trends.
Maybe a similar question, Bruno. I mean, I think an analogy would be like if you go to a really fancy Michelin restaurant and you have an amazing meal, you know, it's not as simple as just telling somebody else just make that meal. Like it's a complex, you have to have the right ingredients, you have to have the recipe, you have to have a talented chef. And I'm wondering if the idea of, you know, Brazil has this amazing data system across climate, health, everything that we can integrate. Why don't we just replicate that in, you know, Uganda or whatever? It seems like just so much to try to do that I can imagine, like how would you even get started? But I wonder if there are ways to break down the data that you have to say, what's the, okay, for the highest burden issues that facing a country, what's the cookbook, what's the recipe of the most critical ingredients that you need so that you can start to build towards that sort of a data platform without feeling like completely overwhelmed that you have to replicate everything that Brazil's done to be able to get something useful out the other end.
We are completely aligned. We have this exact same thought, and so we just got funding to expand the data lake to incorporate all the 17 countries that we operate, that we have. That would be an interesting journey, but when I was talking to funders, what I proposed was exactly that. Like, look, we have data on El Nino, La Nina, I don't know all of those things. So why don't we stick with just a set of 5 parameters that are critical, like pollution, temperature, you know, and we could start from there. So we just got the funding in January, so we are planning to do that. I can answer it in a couple of years. I always is that, but yes, the data is available. It's just a matter of like having access and knowing how to read and integrate with other. Having good servers and having good data sets, right? So we have meteorologists and all that. So it's part of the team. It's not like we're not a bunch of physicians trying to, they are the kings of that. So we, you know, geologists and all that, they're part of the.
So in the second study that you presented, or the third study, the one talking about mitigation of impacts of climate on health due to preparedness. I'm sure there were more nuanced conclusions from that study, and I'd like to hear some of them. But like from a funder perspective, from a government perspective, like what do you do with that? Like I think a lot of us, without having advanced data or without doing analysis, could have been like, yeah, preparedness probably helpful, and we should do something. Like, were you able to specify like which aspects of preparedness mattered for mitigation or not for mitigation of those things? Just how can that conclusion sounds like something that's fairly academic, be translated? Yeah.
Right. So those analyses are ongoing right now. The last draft was 2024, and we are still assessing that. So what happened during our study is that when we had a draft after we actually had studied, right? So it was ongoing, and everything was type of indicating that we would have a prolonged period of drop, and we then negotiate. So what we had discussed with the government, and I think it make an impact, and we discussed this in a paper, is they distributed drugs, for example, TPT, and installed labs with quantiferum or gene experts in strategic regions to prevent collapse in the next drug. So this is just one example, but we still digest. We do have that data embedded in the project.
So Gilbert Burnham in the department, And I had a question earlier about your tuberculosis presentation and talking about Gene Expert. And you showed a huge potential saving of lives and of funds for using this. And I'm just wondering, what kind of impact did this kind of data have on people in the decision-making process? Because it would seem this is data that could be acquired in many places fairly easily. And then the second question is, I'm wondering what potential benefit did the drug resistance component of that have in the treatment programs? And did you analyze that? And was that something that had some potential benefit?
Thank you so much for the questions. So our group, Fiocruz is part of the Ministry of Health, just to be clear, right? So Fiocruz it's not exactly the same, but it's similar to the Brazilian NIH, right? That's why also it was easier to get some of the data that we were looking for. The other thing that makes Fiocruz different than a university there is the proximity to the decision-making people, right? So even before the paper was published, we actually presented the preliminary results to the government. And I'm not sure if it's just lucky, but they listened to us, weirdly. So they decided to actually expand. So there is an entire program in Brazil called Expand TB, right? Expand TPT and Expand testing. So they have invested a bit in new machines and distributing those at the strategic areas, including indigenous communities or in the prison care facilities. We are now doing the same thing with the digital X-rays in the prisons, because I believe that every prison in Brazil needs something like that to just screen at the enrollment, right? But we are very lucky. All of these papers that I've shown to you, they've been extensively discussed. So one very minor thing, that the directional screening, diabetes, TB, was implemented in a country because of one of the studies that we discussed. Like, look, if you have diabetes, you have an increased chance to fail treatment, to die, and to transmit to your contacts. So we need to do something about it. And they've been implementing, Brazil launched it, I think was last year, the Brazil Saudável. He's Brazilian, so it's a national initiative to eliminate most of the socially determined diseases. And that's a huge effort. And we directly participated in the design of the strategies related to TB and HIV. So I feel really confident that they're listening, and the money is still there for this type of project. It's not for research, though. I can't ask money to do research. But if I show to them that the money that Wacom supported can help them to do something, then they invest in the program. So one thing that I learned there, that's why we have fancy names and institutes and NGOs. And if you press the right button, you actually can do all the research that you need without the hassle of writing the projects and the grants for NIH funding. And that's why we survived with $59 million that we got in just to support these studies that I presented to you.
And my second part was about the ability to screen for drug resistance. And did that have any policy implications? And I mean, we're facing this problem with multi-drug resistant TB. And what were the potential implications financially and programmatically from using Gene Expert to look at that?
So our study shows that, well, of course, the detection of drug resistance will increase if you just increase, expand the screening. In Brazil, MDR-TB is not a big problem as it is in India, right? So we have very niched populations like incarceration, that has some problems with drug resistance. My group has not explored this in detail. There is another group there at Rio de Janeiro that is kind of the leading group in drug resistance, and they take care of that. There's another thing about my country, but I found that here is the same. People have different silences, and it's like drug resistance is not what we do, but we provide data for them. They integrated data. We say like, hey, Efranio, take this, and he's analyzing it.
Do one more question if we have any. I have one question just about the amazing Brazilian data. What, not knowing the data, what do you think are the biggest problems or gaps or errors, or what are the challenges in working within the Brazilian data architecture?
So you need to. So when we were building the team to curate that the huge database, we needed to hire people that actually understood biology, right? So and understand the programs of the government. Just an example. A disease definition could have changed over time, and the exams used to diagnose, they've changed over time. So, and that's just or the BMI started being recorded after year X. Gene Expert started in 2014. So all of those things are very dynamic, and you need people that really understand the core of that. To talk together in a collaborative way. So this group really works together, and we meet almost every day to discuss something. So this is challenging, but I think if you have the right people, you can do it. The problem with other groups that I've been seeing is, so the people editing, curating data, the big data scientists, they don't really understand many of that, what is there. Right. So what we found was very simple. If you just delete a column in these like huge databases, you could mess up the entire alignment of the data. And we found that with the government scientists generated data. So the people designing the programs, they were doing wrong. And so we had to show to them, look, guys, everything that you've published until now has a problem because you don't know what to do with your own data. So everybody wants to study those things, but you have to be really prepared and be clear that, look, I'm not an expert in this. Who is? And I will talk. That's why I'm so happy here, Joe, because now I have the opportunity to meet actually experts in fields that I'm not, and we can leverage this interaction, and it's fantastic. Yes, more.
Excellent. Well, everyone, please join me. Thank you so much. One of the goals of this was for all of us to hear what Bruno's doing and really to spur some new collaborations, some new ideas working together. And so please, Bruno now has an office like 5 doors down from mine on the 8th floor. So please make sure you connect. And thank you so much for taking time to do that, Bruno. Appreciate it.
It was great.
I see they're constructing this mesh field or something.
Great.
It's just like it's done like a dark hole for like a year, and it's still a dark hole, but it says it's open by summer.